and thank you for joining today's IARS virtual education webinar called Postoperative and Post-ICU Vital Sign Monitoring in and out of hospital, the status, challenges, and state of the art. My name is Emilie. I'm a postdoctoral researcher in anesthesiology based in Copenhagen, Denmark, and I'll be the moderator for today's session. And before we begin, I'd like to share a few announcements from the IARS. First of all, welcome. And this webinar has received no commercial support. And the call for sessions for the 2027 annual meeting is now open, and the submission deadline is July 15th. And if you missed the 2026 annual meeting, on-demand recordings will be available for purchase starting next month. Please visit the link on the screen for more information. And for information about upcoming webinars and educational events, please visit the IARS website. And finally, before we get started, we'd encourage you to submit questions throughout the webinar using the Q&A function. We'll collect questions during the presentation and save them for the discussion at the end of the session. And with that, let's get started. We're fortunate to have three leading experts in post-ICU vital sign monitoring joining us today. I'll keep the introductions brief and invite each of you to say a few words about yourself before starting your presentation. But joining us today are Professor in Anesthesiology, Dr. Ashish Khanna from the Wake Forest University School of Medicine in North Carolina, Professor in Anesthesiology, Dr. Eske Aasvang from Rigshospitalet in Copenhagen, Denmark, and Professor in Anesthesiology, Dr. Meyhoff from Bispebjerg Hospital in Copenhagen, Denmark. Thank you all for being here. And the first speaker is Professor Aasvang, and perhaps you could begin with a brief introduction of yourself.
Yeah, thank you, Emilie, and thanks to the IARS. Well, my name is Eske Aasvang. I said I am Professor of Anesthesiology. My main research areas is enhanced recovery after surgery, pain, of course, patient monitoring. Together with Professor Meyhoff, I've developed the WARD project, which we will partly present in these talks also. I'll just have to share my screen here, make sure it works. 1 second. Here we go. So my talk is about the monitoring within the hospital, the out of sight but out of mind perspectives that continuous monitoring has. These are my conflicts of interest. So I think it's quite clear to everybody that surgery is not a free lunch. There's actually quite a lot of complications after, and were surgery a disease in itself, it would be the third most likely cause of death worldwide. We also see that up to 40% of patients have complications during their stay in hospital. They're, of course, depending on the size of the surgery and the preoperative comorbidities the patient has. All of this actually results that overall there is around 30% of unexpected critical complications within the first 30 days post-operatively. Quite embarrassingly, you could say 40% of these are actually preventable did we have the technology, the staffing, and the time to intervene. Part of this is somehow should be obvious to us as patients present with vital signs deviations prior to complications. But 90% of these deviations are not detected today. And overall, these complications are not only a burden to the patients, they also prolong hospital stay and, of course, increase hospital costs. So, beginning from the beginning, why do we monitor vital signs? Well, it is, of course, to find those things that precede a clinical deterioration, which is the vital signs deviations. And clinical deterioration precedes adverse events, with, of course, without intervention, can progress into serious adverse events. And this is why, where we normally work, and is as anesthetists, we have continuous monitoring as standard in the OR, the ICU, and the PACU, simply to make sure that things don't progress. So for some reason, we are still there where we at the general ward only have manual intermittent monitoring. And you could argue this is a lapse in logic. Why don't we do this? Because the same things should apply to this setting, only the incidence might be lower. Because the general ward is definitely not the OR, the ICU, or the PACU. To your left, you see a place where I normally work, lots of technology, monitoring, things we can do. On your right, you have what is a modern hospital standard, a single room bed, which actually leaves the patients even without a companion patient to call out if something goes wrong. So where we normally work as our workplace as anesthetist, highly staffed, continuous monitoring, and we can do things when things happen. At the general ward, often there is 10 to 15 patients per nurse, only intermittent monitoring, and very few things you actually can do. You give it a fluid, you can do suction, perhaps sit the patient up and give a bit of oxygen nasally. At home, which is Dr. Meyhoff's presentation, there's absolutely no staffing, perhaps some relatives who don't know what to do, something happens, no monitoring and no interventions. And this is perhaps also reflected in the numbers of mortalities in the hospital. We made the OR, the ICU, and the PACU quite safe spaces, despite the substantial trauma that surgery inflicts. So only 1% of mortality actually occurs where we work. The rest of them is mainly at the general ward or at home. And the number of annual deaths worldwide, as I said in the previous slide, is staggering within the first 30 days. Then you could say you could just hire some nurses. Well, there are basically none to hire anymore, and recruiting them for pay from countries where there might be economic incitement to move to the Europe or the States, I would say somewhat unethical also to drain these places for skilled healthcare workers. So we need to fix our own problems. And one of the things actually that is not upgraded when you have a busy schedule is, sorry, my camera froze, I think, here it is again, is actually the monitoring part. Then what we've done worldwide is we have implemented the early warning score or similar systems, so-called trigger systems, where you manually and intermittent every 8 to 12 hours, you monitor patients. Now, the problem is that if you look at the graph to the lower left, the graph should perform, or the system should perform as the yellow dotted line, where with increased scores, you have increased mortality. This is not the case. Actually, the scores are only correlated to the outcome when you have very sick patients. It's also not done in time and inaccurate measurements. There's a number bias because the nurses don't count the respiration rate, for instance, over a whole minute, and sometimes also report numbers that results in them not having to call the on-call physician. So the effect on mortality is not proven despite case controls and RCTs. And this matters because for every hour we don't detect a sepsis, for instance, the mortality risk goes up. And also that the longer a complication lasts, the mortality goes up as well, as in these two studies shown here. So what we found out in the around 10 years ago was that when we monitored patients with modern saturation monitors, what was found was that a lot of patients actually had severe desaturations lasting for more than 1 hour. This is from the Sun study and from the States. 90% of these cases were missed by the nurses' rounds. We found exactly the same here in Denmark, and other studies have found the same as well. So one of the things we know is that now that all of these deviations are definitely not dangerous because all deviations are not complications. But for some patients, deviations are dangerous, but we don't know who they are for and when it is. And all of these deviations, if we had to alert for each one of them, it would result in massive alert fatigue. Now, there's been plenty of papers about a talk such as this one, stressing how much it could do, how that we should start implementing it, etc. But the fact is actually that for some reason, vital sign monitoring isn't implemented broadly. And some of the reasons are listed here. We need the sensors to be accurate. The connectivity should be smooth, the user design. They should be able to wear it without intervening in everyday activities. alerts, we need to address the massive problem which we might be able to handle in the ICU due to one nurse per patient. In the general ward, we can't handle more than 200 alerts per patient per day. Again, vital signs deviations are not complications. When should we alert and how? To a central nursing station, to the smartphones that people can carry around. Should we alert nurses and also physicians? And we need the evidence that these systems reduce complications, because simply just reducing deviations is not the target. It is actually reducing complications and mortality ultimately. Again, we need something that is not only research, we need something that has gone all the way to become medical products and are regulatory approved. And in the end, this is beyond this talk, we need to address the fact that these systems have to be paid for by somebody, but sometimes those who buy the systems are not the ones who gains. So one department might invest, but it is intensive care who gets fewer and healthier patients. So the ideal patient monitoring should use continuous and wireless vital signs monitors. They need to be multimodal, and there should be few of them actually, so not to burden the patients. The alerts should be made in real time. They should ideally be context sensitive, meaning that, for instance, adjusted to sleep or awake, individualized and risk-based. And we need to send these data to nurses on their smartphones. We don't need risk stratification systems when the patient is admitted, because these systems will not tell you anything that this patient might be at risk during admission. We need to know when something is happening actually. But we also need to know that this patient is stable, because that allows the nurses to move away from the patient and attend to others. Ultimately, we need to rely on the staff's training and what the interventions they are able to do. We do believe that that staff is well educated, are actually able to intervene as they should. And ultimately, the rapid response team activation should be a backup, not the standard. So when we build these alert systems, we should start by building the evidence for the thresholds and the alerts. This is one project from our group where we've monitored 500 patients after surgery. What we saw in this setting was that all the patients had vital signs deviations, but the things that separated patients with complications for those without were that once they had deviations, those lasted longer times. And of course, we should try to tailor the alerts according to this, and I will get back to that. This is a paper that's just been submitted. This is actually patients without complications. And what we see here on your left is actually that minor saturation deviations is quite frequently occurring in patients. And of course, the more severe the desaturation is, the shorter time it lasts. These are 10 minutes, 100 minutes, and 1 minute here. Now, what's very rare to see actually in patients without complications is, for instance, tachycardia. So again, now we're starting to build the evidence for actual alert thresholds. So for instance, a patient with a tachycardia above 110 lasting more than 10 minutes, this is absolutely significant. And you might also have other solutions as how to reduce alerts. So this is a Dutch group, and what they've done here is they try to do adaptive threshold-based alerts. What you see here then is actually that they have a very high alert rate of false alert, again, resulting in lots of alerts sent to the nurses in the department, and also perhaps one of the reasons why this system hasn't been implemented. The other, you could say, end of the spectrum is simply just to define that we don't want more than 1 to 2 alerts per patient, regardless of what happens. I mean, this, of course, will reduce the number of alerts, but it's not really sound, because, I mean, the patients might need to have the alerts if they are substantially ill. And ultimately, of course, you could do as the early warning early warning score system, simply don't alert. But again, then we don't find any patients. So what we suggest is to try to mimic clinical practice when building alerts. So this is a very simple representation where we combine duration and severity. And of course, a simple rule is severe deviations are more harmful than minor, longer deviations are more harmful than short. And compensatory mechanisms, such as a relatively low blood pressure and a relatively high pulse, that combination is something that triggers experienced physicians to say something might be going on here. And this is basically how anesthetist thinks. And we've termed this the anesthesia coffee principle. Ultimately, if it's a minor deviation, we'll say, I'll come back once I've had coffee, because we know the majority of deviation goes away by themselves. If it is a severe deviation, we say, hold my coffee, and then we immediately attend the patient. Sorry, tongue in cheek here. Now, when doing this trick about combining severity and duration, and this was in 700 patients, what you see is actually that you have a substantial alert reduction when you combine artifact removal and our AI. And you still preserve your sensitivity for complication, which is ultimately what we aim for here. So this is something that points us in the right direction. What these systems also do is actually that they free up time for nurses. And this is a study by Emilie, who's chairing this session. She showed that for on average, you saved around 10 minutes per patient per day. And of course, the more sick the patient is, the more time you save, because we require them to be observed more frequently manually. And also, these systems actually also has another benefit, which is it reduces the cognitive stress and the burden. So you have this increased sense of security in nurses and patients, and you are able to have timely interventions. And ultimately, as I said in the beginning, what we want is actually to detect things earlier than we do today. So this was a study with around 400 patients after major surgery, where we looked at when do the staff actually note that something is going on, something might be wrong, and when do these systems then, compared to that, start to alert that something is wrong. And what you see here is that the clinical suspicion is on average only happening around 13 minutes before the complication is actually diagnosed, which is very, very close to it. The alerts from these systems are actually able to pick something up almost 2 days before, giving us time to intervene, of course. And with this, I'll leave the floor to Dr. Khanna to present more evidence. Thank you.
Hey, well, that was a great talk. Thank you, Eske. Sets us up really nicely for the next talk right here. Let me just share my slides. Okay. All right. So yeah, this was a great setup, and like I said, thank you, Eske, for leading us to this point. Um, just by way of introduction, Ashish Khanna, professor of anesthesia and surgery and vice chair of research at Wake Forest, and I've been invested academically in this space of continuous vital signs monitoring for nearly a decade now. And today I'm going to talk about the evidence and set up really nicely with the talk that has preceded me. I'm going to lead you into sort of the current state of the high quality evidence and maybe make you think about what needs to be done in the future. So let's see, advance this. All right, so these are some of my relevant disclosures. Disclosures here. We were already talking about all of this, but just to re-emphasize, I mean, I love to show this infographic. Intraoperative mortality is just a mere 1% of total 30-day mortality. So this yellow dot here is intraoperative mortality, and the big gray circle is total 30-day mortality. So we do a great job as far as taking care of our patients in the operating room is concerned, but those patients are clearly not making their way home, and the real danger here is the fact that they are dying in the hospital under our care. And there's several layers of data and several years of studies that have come out. I've quoted some of the data on this slide. The bottom line is that not only do patients die on the general hospital floor, this mortality contributes to about 85% of all postoperative mortality. The really important point is that a large chunk of these patients can be identified about 24 hours before the adverse event. in the last talk was phenomenal, where, we saw that, we can identify these patients about 2 days before the adverse event occurs. But on clinical suspicion, we don't really have time to identify them. So makes me think what we can do better on the floor. And indeed, we leave our patients under monitored on the floor. This slide is coming from Michael DeVita. For those who don't know, Dr. DeVita really set up the rapid response program in the United States, and I love the header on the slide that says deterioration is a rocky road and not a smooth slope. So the patient has had a deterioration event here, where you see the big yellow arrowhead, a real clinically significant event, but if you look at this composite of heart rate, respiratory rate, oxygen saturation, and blood pressure that's represented as this body signal, biosignal index, that index has deteriorated gradually over time. And we were given lots of opportunity here to intervene early to prevent this actual downstream event. This type of data, we can go on and on, and we can talk about it further. But before I jump right into the evidence, I love talking about the aircraft cockpit concept.
Mm.
There is Every modern day airliner has to have a flight data recorder and has to have every single movement and pilot input and behavior of the aircraft recorded in the flight data recorder. This has made aviation way safer, and we continue to get safer, even though we fly more aircraft now in the sky than ever before. We don't make presumptions when it comes to aviation. We don't presume that everything is safe just because, the weather looks good outside and we can just fly the airplane. But we do that to our patients on the floor. We make the presumption that they are fine. That's why they're on the floor. So we don't need to record their vital signs. Clearly, we're not learning as far as monitoring and wearables are concerned from the aviation principle, and we need to do a better job. So, with Bernd Sagel and myself and Morris Flick, we wrote a really nice review here for the BJA, where we talk about all of these concepts, and we give this comparison of sort of the current state with intermittent monitoring here in the top part of this infographic, and the future state with continuous wireless wearable monitoring, the closed loop response system, and definitely an early response. And you might say, oh, this really seems like common sense. Really, anyone could understand that we need better monitoring and we need to intervene earlier. So why aren't we doing it? Well, I'll talk somewhat about the barriers today, but one part about it is being smart. So choosing the right patient, choosing the right monitoring solutions, choosing the right alarm thresholds. Um, can we provide effective responses on the floor? We clearly don't want to take every patient who has some sort of vital sign deterioration, put them in the ICU. That's not the objective of better monitoring on the floor. And can we provide effective treatment that would actually prevent ICU admissions and take care of patients better on the floor? So there's a lot of unanswered questions that we need to think about. Anyway, talking about evidence, I'll start with the blood pressure side of things first. So this was a study that was done at the Cleveland Clinic, about 500 odd patients after major postoperative non-cardiac surgery, where we put continuous vital signs on them, and we blinded those vital signs monitoring systems. We had lots and lots of hypotension in this particular analysis. So, for example, here about a fifth of all of our patients spent at least 15 continuous minutes under a MAP of 65. More importantly, when we compared routine nursing checks to continuous monitoring, about half of all episodes of MAPS less than 65 were not detected with routine spot check monitoring. So postoperative hypotension was common and undetected. Now, at Wake Forest, my institution, we have, or we for a large period of time, continuous monitoring as a standard of care. And when I looked at our data, this is about 15,000 patients now, with monitors and alarms active and interventions being done. We did not have as much postoperative hypotension here, only about 10% of patients, that's the y-axis here, having a threshold map less than 70 for at least 30 continuous minutes. So it's not a direct apples to apples comparison with the Turan study in anesthesiology, but definitely a big decrease in the amount of postoperative hypotension using real world data and a much larger data set for that matter. The Prodigy study was briefly mentioned in the previous talks. An important study, a prospective study looking at opioid-induced respiratory depression in adult patients recovering from non-cardiac surgery and also medical patients on the floor. They were subjected to continuous capnography and oximetry. And the data was significant. About half of the entire cohort of about 1,500 patients, 1,381 to be precise, had at least one opioid-induced respiratory depression episode that was detected with this continuous capnography and oximetry. Again, meaning to tell us that there is a burden of both hemodynamic instability and respiratory instability on the floor that we're not capturing with our standard right now, which is just intermittent monitoring. So the people ask me, okay, that's great. What are the big implementation challenges? Why can't we implement all this? The three big things we did the survey that we published that stood out were return on investment, connectivity issues, big issues, and alarm management. And I really stress on the fact that alarm management, if you ask our nurses on the floor, no one wants false alarms. No one wants nuisance alarms. Eske has already talked about this study, so I won't go into the details here. But here is what we need to do going forward. We need more technology that can clean up the false alarms and separate them from the true signals so our nurses, our resident doctors on the floor, the primary responders to this continuous monitoring can focus in on the patients that are likely to deteriorate. The other question is what wearables? So there is some interesting data around that. The most important signal appears to come from continuous respiratory rate, here in this study being the biggest predictor of a actual downstream clinical event. And why is respiratory rate critical? Because ironically, it's always the one vital sign that is never measured correctly. This is real world data from another monitoring device. The big yellow dots are intermittently checked respiratory rates done manually. They are always the same number, around 16. The blue dense dots are what the wearable is capturing. We draw a line through those dots. We can see that the trajectory is a worsening respiratory rates, increasing tachypnea. The purple here is an actual ICU transfer event. Ironically, the last recorded manual respiratory rate is still 16, right? So again, such a simple vital sign, not measured, and the data suggests that it can really help us intervene early. So what about hard evidence? Hard evidence meaning clinically significant events like ICU transfers, mortality, cardiac arrests, and in-hospital mortality. There's very few randomized trials, if any. I'll talk about them. Most of the evidence is prospective before and after type studies or propensity matched analysis that some of our group has done. Now, in all of this, the before and after studies, there's a lot of them that point to actual outcome benefits. I have them on the slide. I won't go through each of them in detail, but almost all of them point to either decrease in rapid response or decrease in cardiac arrest or decrease in rescue events. The one red arrowhead is a study that was done at our institution in a neurological and neurosurgical patient population, where we again saw a significant decrease in rapid response team events when we implemented continuous vital signs monitoring. The few studies I will talk about, this is work from that was published in the BJA about 4 years ago now. Again, this group saw that continuous vital signs monitoring did significantly decrease both unplanned ICU admissions and rapid response team calls. The decrease is statistically significant. It's an important before and after study. although we always call to question sometimes the statistical robustness of before and after analyses, but still the signal is strong and it's pretty clear here. Now, our group has done similar work. We propensity matched about 20,000 surgical patients getting continuous vital signs monitoring. Within these 20,000, there were some that did not get continuous vitals and just got intermittent vitals, whereas there were some that got continuous vitals. These were effectively propensity matched, and the outcome here, the primary outcome was a composite of in-hospital mortality and ICU admission, which was in favor of continuous monitoring, and the organ system failure and was also in favor of continuous monitoring. So again, strong signal towards continuous monitoring in a propensity matched surgical cohort. We repeated that experiment with 7,000 medical patients here at Wake Forest, and very similar signal with both ICU mortality and ICU admission, largely in favor of continuous monitoring, composite outcome in favor of continuous monitoring. The organ system failure outcomes here crossed over and were not statistically significant. We've summarized some of this data in this nice review we wrote for BJ Education. We talked about all of these studies, 1,000+ patients, lots and lots of data now. At that time, there were no RCTs, but again, the conclusion was less RRTs, less ICU admissions, and less mortality with continuous monitoring. Now, what about randomized trials? And I'll say there's two really important ones, and interestingly, all of us are on this webinar who published those trials from Eske and Christian's group. This really nice randomized trial in 400 patients, 200 in each group, more than 50 years of age, more than 2 hours duration of surgery, major surgical interventions, randomized to standard of care, intermittent ward monitoring versus standard of care monitoring continuous monitoring added on with this device system that was generating real-time alerts going through smartphones and a layer of alarm and artifact filtering. So the outcomes here were severe deviations in vital signs. One of the biggest signals here was less hypoxemia in the group that was randomized to the continuous monitoring plus the real-time alerts to the nurses, along with alarm, artifact filtering. The other really strong signal was survival curves in terms of the adverse events and serious adverse events, at least with the adverse events reached statistical significance all the way out to 30 postoperative days. So really nice signal. Focused the hypoxemia part stood out and the adverse events part stood out. What was really credible was there was some sort of device that was acting at a post-processing stage with all of these continuous vital signs and making life for the nurses and primary responders easier. This is our trial that we just published earlier this year. This was 2 hospital ward units that we randomized every 4 weeks to go from continuous monitoring to intermittent postoperative vital signs monitoring. So it was a pragmatic trial. Every patient on these 2 floors was a part of the trial. We only included patients with high risk, that's more than 45 with one cardiovascular risk factor or more than 65. And the analysis and the data here is interesting, but sort of similar to the work from our Danish colleagues, where our signal was strongest for the difference in hypoxemia. So the 2 groups had about 400 patients after we had excluded everything else. When we looked at the risk of getting hypoxemic, it was in favor of continuous monitoring, so decrease the risk of hypoxemia right there. As far as tachycardia and hypotension is concerned, that did not reach statistical significance. We also looked at various other thresholds of blood pressure and heart rate and various composites. The composites were also in favor of continuous monitoring, but individually the components of the composites were not. This is another way we've presented the data in the paper. We've looked at actual durations of time, durations in minutes per 48 hours of monitoring in each of the two groups. Again, the SpO2 less than 90, there was about a half an hour difference. Now, you might say a half an hour difference is a lot, but if it's half an hour over 48 hours, I would also question the differences are not sustained hypoxemia in most of these patients, or probably spurts of hypoxemia. This is what the SpO2 overall looks like, and we have patterns like this for each of the vital signs. If you read the paper, then the red is continuous monitoring, and in the blue is standard monitoring, and there is separation, decent amount of separation. But if you look at the x-axis, the percentage of time, that is still a fairly small percentage of time that is spent beyond these critical thresholds. What was the most interesting to me or important as far as I'm concerned is that we looked at hard outcomes differences in both the groups, right? From in-hospital mortality to rapid responses to ICU transfers and so on. And over there, even though it did not reach statistical significance, our adjusted risk reduction was the point estimates trended pretty strongly in favor of continuous monitoring. So there was less events on the continuous monitoring side. So I could argue that if this was a trial of, say, 5,000 patients, we would have probably reached statistical significance in some of these hard outcomes. And what really matters is the hard outcomes in the end. Dan Sessler has done similar work with this Cosmos trial, looked at 5 vital signs thresholds. And again, it appeared that oxygen desaturation and respiratory rate, at least the point estimates, were in favor of the continuous monitoring. So again, Cosmos was a small trial, and there needs to be larger trials if we are going to aim for statistical significance. So as I come to the end, I'll say that there is so much to do, right? I mean, wearables are important. They are here. They're all around us. We wear them. Our patients are not getting the advantage of wearing wearables, and for us to see their data, we must continue to build evidence for hard outcomes. But really, we must realize that it's an experimentation with the human factors. How do we engineer these devices to actually allow us to see best signals so we can intervene on our patients earlier and faster and make monitoring a more useful exercise? I end with this, that, Dan Sessler is really impressive. Rovenstein lecture in 2013 called The Gathering Storm, where he said intensive postoperative monitoring might be a new branch of anesthesia that's headed our way, and we need to really take charge of it as anesthesiologists. So whether we like it or not, coming soon to a hospital near you might be some sort of continuous monitoring device system that we need to adopt, and we need to think how we can work with it to best benefit our patients. Thank you so much for your time and attention, and I will now turn it over to Professor Meyhoff for his talk.
Thank you very much, Professor Khanna. Very interesting findings and perspectives also from your recent trial. So I will move to home monitoring, continuous home monitoring of vital signs. This is a new area. We have in Copenhagen, together with Professor Aasvang's group, in our project investigated this over the last 5 years, and also the moderator, Dr. Emilie Sigvardt. I am professor in anesthesiology. I work at the General Hospital in Copenhagen, Bispebjerg Hospital. My disclosures are here. I'm founder of the WARD project, so the algorithm, the monitoring solution, the clinical support system. We have patent filed, and you can see the MDR certification here. It is, in fact, also a product that is FDA cleared and on the US market. Going to the home situation, it actually puts the in-hospital situation much more to the edge, because our future healthcare, it must incorporate digital home technology in order to overcome the double demographic burden, to increase healthcare capacity and make sure patients do not get readmitted while we clear the hospitals. And we must do that while still improve health economy. Fortunate, the technological situation is good and patients are very engaged with their own care at home. And we see an increasing focus and collaborative environment for this. And it makes good sense to focus on the home setting as well. Even from our specialty, anesthesiology, where we're used to care for patients in the PACU. And as you can see here, the most dominant post-op complications are here. We can see in the PACU major bleeding, we can see MINS beginning to occur. That's also the significant complication in the post-op wards. But the majority of complications, they arrive when patients are at home. And you can also see, these are data from the large global vision study. The attributable fraction of 30-day mortality is profound for all these three complications. So if we can diminish them just a bit, we impact healthcare fundamentally. How to do that? Well, this is an example. And I'll not present many RCTs in this talk. The home monitoring is not yet as investigated as the in-hospital setting for continuous monitoring. But standard of care today, I'm sure you know this patient, 74-year, admitted with heart failure and also a bit of pneumonia. It stabilizes, but the transition to home or a rehabilitation facility contains a lot of not step down, but fall down strategies. Vital signs are not checked regularly. There are no blood samples. When the deterioration arises and a new second pneumonia arises that may develop into septic shock, we also know a patient like that may face significant challenges or even death in the ICU for treatment of this. The same patient could, with optimized home monitoring technology, already be known better by staff through continuous monitoring in hospital. When the deterioration and the secondary pneumonia arises, we may detect that with point of care tests at home. We may also detect it with continuous monitoring so that when the complication arises, we can escalate treatment early, so it's much more effective. It may result in a hospital readmission, but that will be of shorter duration and the patient can go home again. What is important and where we need implementation is that this is in fact 4 different technologies that are already available, but we don't use them regularly, and that's why we can fundamentally increase healthcare if we go with these solutions. As mentioned by Professor Aasvang, we have the choice today in order to improve safety and security. Of course, the first choice is to not do something. That is option 1. Option 2 is to apply ICU, operation room technology, continuous monitors in the hospital wards or at home. That will simply result in alarm fatigue with too many alerts. So our ward system is an intuitive clinical support system with AI-based alerts that filter the alarms and only alert staff when needed. Actually, an option 0, that is to clear the hospital and make the patients go home, because there are absolutely no safety and no monitoring at home. But I'll just leave it like that, because I think home monitoring today is not at the expected level for many of our risk patients. As mentioned before, the ward clinical support system is built based on documented evidence as part of our MDR certification, such as when a tachycardia becomes important for patients, what is the duration of hyperventilation that is allowed before an alarm should be triggered. That's what's all combined into the clinical support system, where you see the graphical user interface, meaning this is the app that may be activated on the nurse's smartphones. When the nurse wants to check the patient, she or he can do that at the specific time point. It's possible to document vital signs in the electronic health record. And the most important feature is that the clinical support system will only make sound and visual alerts when it's important to attend the patient. So it can be carried in the pocket. You know that if something occurs to your patient, you will be warned at that specific time. And that allows a fundamental change of our healthcare. Because if we want to increase safety and quality and capacity of our healthcare system, there's actually a lot of things we can and should involve us in the home setting. First, of course, to prevent the patient having the severe complication and thus being readmitted. So if we can prevent a deterioration to becoming a complication and that complication to become severe complication, we will reduce hospital beds due to fewer readmissions. We may also prevent a patient from being admitted to hospital if we employ continuous monitoring after contact to the emergency medical services if patients do not require specific hospital evaluation or treatment. We may also continue the in-hospital level of monitoring in transitional care facilities where staff is less available and patients are still at a much higher risk. And we can do it in nursing homes as well. I'll come back to that. But one ICT I need to emphasize is from Canada, the PVC-RAM1 trial after acute surgery, where more than 900 patients were randomized to receive either virtual care, that was point measurement of vital signs, and video calls to nurses once or twice daily. And as you can see, it didn't reach statistical significance in preventing acute care in hospital, but the signal was definitely there. What did reach significance was the number of drug errors corrected. So the fact that being able to monitor patients' vital signs at home, that led to the caregivers, the nurses in this case, to correct some drug errors. And I think it's perfectly fair to say that in our very busy healthcare today, drug errors occur, other errors occur, and if we monitor, we might get our eyes on them and be able to correct them. It's very important. I'll share some of our data from Copenhagen. This was a transitional care facility where we monitored only 20 patients. They were admitted there after hospital stay. Their vitals were normal when they were arriving in the transitional care facility. The nurses there, they measured vital signs in 11 out of these 20 patients with no documented deviations. At that time, our clinical support system didn't have the alert app available, so this was shadow monitoring, but I'll share what we found in the vital signs. We found fundamentally large deviations. 90% had severe desaturations. There were also bradypnea, tachypnea, and tachycardia to a very large level. The patients also had 35% risk of a complication and 40% were readmitted within 1 month. I'm not saying we can prove association, but definitely there is a signal there to improve care. And we conduct larger studies at the moment, which is part of the PhD thesis of Emilie Sigvardt, where we have included large patient series in either medical, emergency, hematological departments, and also documented technical scalability. So to wrap it up, of course, in-hospital monitoring continuously, that matters a lot, and we can prevent many complications there, in my opinion, but also areas out of hospital. I think our specialty should be involved in this in order to increase safety and quality and capacity of our healthcare system. I'll just show a few examples here because the list is really, really long. Why don't we monitor patients after high-risk surgery, where number of readmissions are one of the highest? Why don't we detect infections when we discharge patients that still have ongoing infections with antibiotics at home? If we initiate rather potent drugs for alcohol withdrawal treatment, why don't we attach continuous monitoring to make sure nothing goes wrong? If we want to initiate specialized home treatment, such as blood transfusions at home to increase the hospital bed capacity, why don't we do that with continuous monitoring? Thank you.
Thank you, Professor Meyhoff, and thank you to all three speakers for sharing your insights with us. So let's move into the Q&A session. Please feel free to submit any questions you might have through the Q&A function. I can see that we have one question from the audience, and here it goes. How to identify patients at risk when 3/4 of patients who die are not admitted to the ICU, and not identifying them lead to admitting to a general ward leads to less intensive care. Will continuous monitoring be equivalent to ICU level monitoring, and what are limitations compared to ICU? Although ICUs provide more than just monitoring, I think the emphasis should be on identifying those 3/4 of patients and admitting them to the ICU or HDU.
Thank you. That was a lot of questions. I'll be happy to start by replying to some of them. And I'm sure actually we can have a rather good discussion around this. First, which patient to monitor? That's a very common and very relevant question. In our hospital, we have a large, very young population undergoing elective knee arthroscopy. Healthy population, number of complications almost non-existent. So everybody agrees at the point now, they should likely not have continuous monitoring. On the other hand, a large group of elderly patients admitted for acute medical disease, undergoing medium to high risk surgery. I would not expect a system like our healthcare system at the moment to know exactly this patient will have a complication, so you must have continuous monitoring. Continuous monitoring, that's a screening tool, and you need to screen a lot of patients that do not develop complications. So to put it in other words, our best estimate is to say that, well, those at highest risk in hospital, likely the highest quarter, so the 25% that has the highest risk of a complication, I would expect that area to be the most relevant. And of course, some of them likely they will not have complications, but that's how it should be with monitoring.
Yeah, and I'd say I agree with those thoughts, Kristen. It's very difficult to identify patients at risk. My general thoughts is that we can look at the more than 65 age group or more than 45 with one cardiovascular risk factor, at least as a starting point. There are some risk prediction tools that have been built. With Prodigy, we built a opioid-induced respiratory depression risk tool. There's other tools that have been built too. There is no absolutely clear-cut way of saying who's going to be at risk and who's going to not be at risk, but I think at least in a population that is older and has underlying comorbidities, I think there is no reason not to monitor them. I also think of a future state where you would monitor everyone, but I don't think you're there yet, just because we don't have the right tools to deliver the continuous monitoring signals to those who are going to intervene effectively. And that is my worry right now with trying to monitor everyone. We are not.
I actually agree, and I'd just like to add that I think we shouldn't do the same mistakes as other technologies in medicine, where we implement monitors or vital signs that really doesn't reflect physiology. And I know we're all very fixated on blood pressure because we can monitor it, but it is not perhaps the best physiological parameter compared to some of the others, especially within vital signs monitoring. It is very cumbersome to monitor, and all of these mathematical models that try to estimate it require some sort of calibration every time something drops, which is then makes it useless. So as the data seems to suggest, both from your studies, Dr. Khanna, and from ours, is that perhaps we have a very simple parameter or two simple parameters which we can monitor easily, which is heart rate and respiration rate. And that actually allows us not to start out at the ICU level where we monitor everything we can, but we start by monitoring something very simple. And once that goes outside the normal parameters, then we escalate. And I think this is the future, that we choose those things which we know, because we all know that a patient with an increased heart rate, that is not normal. When we see this in the wards, we become frustrated because either it's pain, it's hypervolemia, whatever it is, it's increased temperature. But then we can always examine further. And this will actually then allow us to monitor on a much, 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 much larger scale than we do today.
Another great question was that, will this reduce the number of ICU beds or the need for ICU beds? One answer could be, yeah. So if you prevent the most severe complications in our healthcare system, then eventually the number of ICU beds will be less. But it's definitely not the ambition of a continuous vital sign monitoring system to take the ICU out and put ICUs in home or in the different wards, because in the following minutes and hours of vital sign deviations, that also require the skills of ICU nurses and doctors, and we cannot yet put that into the system. But it can allow ward nurses to react and use the intervention being available in the wards. And then if a complication escalates beyond that, then of course ICU is needed.
Thank you. We have two more questions from the audience. The one is, what is the number of events that you're trying to pick up? That is, how many true serious conditions that will require prompt intervention will occur in 1,000 patient days? And how many false alarms and true but non-actionable alarms will occur in 1,000 patient days?
Okay, Kristen, do you want to start with that? And
it's a very good question. I think we can both try to reply. It's context sensitive, so it depends on the level of risk you are monitoring. If you monitor the sickest patients, almost no false alerts will be there. If you monitor the healthiest patients, a large number of false alerts will arise. In our publications also that Professor Aasvang referred to, we do have calculations of how we do it. So that will be my initial reply.
yeah, again, this is a really tough question because we really don't have a clearly defined patient population yet, right? So once we clearly define our patient populations, we can probably be able to say very clearly. The other way I look at it is sort of what we do with, for example, pulse oximetry. I mean, there was a time 40 years ago, 50 years ago, it wasn't a routine to put pulse oximetry on anyone. We don't see, fortunately, we don't see intraoperative sudden catastrophic events happen anymore. That doesn't mean I stop putting a pulse oximeter on my patients intraoperatively, right? So going with the same logic, I think the important part is that even if there is a very low number of events per 1,000 patient days, that event that is happening for that one patient is a totally avoidable event. And it is unfortunately a catastrophic event when it happens. So that the reason it should not necessarily just be the number of events per 1,000 patient days. It's the fact that it's a totally avoidable event when it does happen, and it's a totally preventable cause of a poor outcome.
So I again, sorry, my camera is not working well. I would add, it also depends on what event we talking about. Of course, if it's cardiac arrest, I would be willing to monitor lots of patients to find that one young person I will save. If it's food fungus, I would definitely require no false alerts in that condition. So again, coming back to whatever all this we're talking about, we need to find some sort of sweet spot where we make it simple enough to monitor, but we pick up the very severe events. Yeah.
Thank you. That was a very interesting point. And the last question from the audience is, do you see continuous monitoring may go beyond the traditional vital signs as it has more capabilities over intermittent measurements? For example, mobilization of the patient could be one important sign too worth monitoring.
Yeah,
absolutely. I mean, if we don't all say, all three of us or four of us in this session say yes to this, then who are we then? Of course, we should incorporate modalities that might be much more relevant than what we have today. What about lactate monitoring? Should that be a continuous vital sign? Well, let's do the trials. We're open to do that. Should we detect falls? Should we detect breathing sounds? Very welcome.
Yeah, 100%. It's a fascinating new area of discovery. There is published data around mobilization now, and it's so important that we need to not just focus in on, oh, okay, we are only monitoring vital signs, but we're actually monitoring a full biophysical profile of a patient, and we must look at all of these other data points as well.
Again, absolutely agree. And also to try to look at trajectories, for instance, and with activity, so that if you have a patient who's quite mobile or has increased mobilization, then we say you're ready to be discharged because we have the data, for instance, at that time to say this patient will always have a home course. Otherwise, if patients who start to being active but then have a sudden drop in activity, maybe they should be contacted and say, hey, what's going on here? Is there something on the way?
Thank you. We don't have any more questions from the audience, so maybe I can close the discussion with a question of my own. And so if you were advising a hospital today, would you recommend waiting for more evidence, or would you argue that we already know enough to start implementing continuous vital sign monitoring? So do we need more RCTs, or do we need more implementation?
Wow. I knew the most difficult question was going to come from the chair of the session. Okay, this is a discussion for maybe an entire 1 hour of a panel discussion. But Emilie, what I say is I think what we've done so far has shown us some clear signals. There might not be statistically or mathematically significant, but the signals are pretty clear. It should not stop us from starting the process of implementation. Evidence building should go hand in hand with implementation. So we shouldn't be like, oh, we need 10 years or more evidence to start implementing it. I think we need to start implementing it. And as we implement, we can build more evidence. I think if we keep waiting for that 20,000 patient trial that will show a survival benefit, then we're not going to do this, which seems pretty common sense now with all of the signals that we have in our hand.
Absolutely agree. So the suggestion, go implement. If you are a leading hospital, implement while you collect data. And also, to be honest, the 3 sessions here today present great amounts of evidence for benefit of continual vital sign monitoring. And we also know for sure that the level of evidence is much higher than when we implemented the National Early Warning Score, which was at a higher evidence level than when we implemented the pulse ox. So we are at a very good and secure place. All evidence is not being made yet, but we have very strong signals that this will improve patient care.
Again, it's easy to come here after these two gentlemen, but I also would argue that actually there are something that hasn't been done in other things we have implemented. There are actually a health economic analysis that shows that these systems actually has a return on investment within a very few months. This, of course, is far down the agenda when we are clinicians talking, but when we're talking to the people who have decided if we get to use these systems, this just adds to the positive side of these interventions.
Thank you. So it looks like we've addressed all questions, and so I think this might be a good place to wrap up. Thank you again to our three speakers for an interesting discussion and for sharing your expertise with us today. And thank you to everyone who joined us and submitted questions. I hope you've enjoyed the session and found it useful. So thank you.
Thank you so much. It's a pleasure.
Thank you very much.
Thank you all.
Bye.
Bye.
Thank you.
Bye.